All you have to do is listen to this video at 2x for 3 times, and you will memorize the entire lecture and you are ready for the exam. So starting with thyroid disorders in pregnancy. Physiological and pathological thyroid changes during pregnancy. Physiological changes. Size of thyroid increases. Goiter is pathological. Thyroid profile. Pregnancy is a euthyroid state. TSH normal or slightly elevated. Alpha unit of HCG similar to alpha unit of TSH. Decreased stimulation to thyroid gland. Total T3 and T4 increases. Thyroid binding globulin increases due to estrogen. Free T3 T4 normal. Increased T3 T4 binds to increased thyroid binding globulin. RD of iodine is 250 microgram per day. Fetus less than 12 weeks, first trimester. Thyroxine production by fetal thyroid gland dependent on maternal thyroxine for development. More than 12 weeks, thyroxine production by fetal thyroid gland starts. So less than 12 weeks, there is no production by the fetal thyroid gland. Thyroid pathologies. Hypothyroidism. Most common cause is Hashimoto's thyroiditis. Maternal T3 T4 can cross placenta. Maternal thyroid stimulating hormone cannot cross placenta. Hence, if hypothyroid patient conceives, increased thyroxine dose by 30 to 50%. Hyperthyroidism. Most common cause is Graves' disease. Drug of choice is propylthiouracil. First trimester, propylthiouracil. Second and third trimester, second and third trimester, methimazole, carbimazole. Contraindication in first trimester due to risk of aplasia cutis more than clonal atresia. Thyroid storm. Contraindication is radioactive iodine. Thyroid storm. Drug of choice is propylthiouracil. Symptomatic treatment is propranolol. Diabetes in pregnancy. Carbohydrate metabolism in pregnancy. Insulin resistance. Hormones associated are human placental lactogen, estrogen, progesterone, prolactin, cortisol. Human HCG, no insulin resistance. Progressing gestation, increased human placental lactogen secretion, increased insulin resistance. Significant insulin resistance develops around 24 to 48 weeks of gestation, pregnancy diabetogenic state. Gestational diabetes. Normoglycemic female conceives, insulin resistance becomes diabetic female. Other features. Maternal insulin doesn't cross placenta. Maternal glucose crosses placenta. Fetus dependent on mother for glucose requirement. Glycosuria normal in pregnancy. Note: maternal thyroxine crosses placenta. Pregnancy complication of diabetes. Fetal absorption of glucose, maternal. Fasting hypoglycemia. Advise avoid fasting in pregnancy. Postprandial hypoglycemia due to insulin resistance. Fasting, vomiting, diarrhea, hypoglycemia, acetone bodies formed, ketosis. High risk pregnancy. Hyperglycemia, fetotoxic, increased free radicals, crosses placenta, congenital malformations of fetus. Classification of diabetes in pregnancy. Pre-gestational diabetes and gestational diabetes. Pre-gestational diabetes, also known as overt diabetes, diabetic female conceives, increased blood sugar from day 1, formation of free radicals, congenital malformations that does not resolve post-delivery. Gestational diabetes, normoglycemic female conceives, develops insulin resistance, develops diabetes, increased blood sugar from 24 to 28 weeks, free radicals begins to form, crosses placenta after organogenesis, no congenital malformations, resolves within 6 weeks post-delivery. Priscilla-White classification, type A and non-type A. Priscilla-White classification, type A and non-type A. Type A is gestational diabetes, non-type A is pre-gestational diabetes. Gestational diabetes type A is further classified to type A1, type A2. Type A1, gestational diabetes controlled on diet. Type A2, gestational diabetes controlled on treatment. For example, insulin and metformin. Development of gestational diabetes mellitus, usually between 24 to 28 weeks, can be seen in less than 20 weeks. If diagnosed in less than 20 weeks, usually pre-gestational diabetes. Confirmation 1x sugar levels by 6 weeks postpartum. The normal sugar levels are retained. Investigations, TIFA, targeted imaging for fetal anomalies, done in all gestational diabetes and pre-gestational diabetes, done at 18 to 20 weeks of gestation. Management, blood sugar levels 2 hours postprandial, more than 200 milligram per deciliter. Always give insulin 8 units irrespective of gestational diabetes or pre-gestational diabetes. Pre-gestational diabetes criteria: blood sugar level fasting more than 126 milligram per deciliter, 2 hour more than 2 hour postprandial 200, random blood sugar more than 200, HbA1c more than 6.5%, DIPSI test recommended by Government of India at first ANC visit. HbA1c risk assessment tool for congenital malformations, gross congenital anomalies. Assessment risk of gross congenital anomalies: less than 6.5%, no risk; more than 6.5%, 3% risk; and more than 10%, 15 to 20% risk. So when HbA1c is less than 6.5, no risk; more than 6.5, 3% risk; more than 10%, 15 to 20% risk. Goal of therapy is to reach less than 6%. Investigation: initial ultrasound, screening test level 1 ultrasound, diagnostics tool TIFA level 2 ultrasound, karyotyping not done, detects chromosomal anomalies, not gross congenital anomalies. Complications: congenital fetal malformations. Most common system involved is cardiovascular system more than cranial CNS. Most common congenital malformation is ventricular septal defect more than neural tube defect. Most common cardiac malformation anomaly is ventral septal defect. Most specific cardiac malformation anomaly is transposition of braid arteries. Most common cardiac finding is hypertrophic obstructive cardiomyopathy. Prevention of gross congenital anomalies: strict glucose control, HbA1c less than 6.5%, risk of gross congenital anomalies is nil. Switch patient to insulin before conception or on confirmation of pregnancy. Folic acid 400 microgram per day. Begin 1 month prior to conception. Continue for 3 months after conception. Other complication of pre-gestational diabetes increased risk of pregnancy-induced hypertension, polyhydramnios, infections, asymptomatic bacteriuria, increased insulin resistance throughout pregnancy, fetal macrosomia, management of please subscribe to my channel. I will show you real life prenatal clinic examples, how each multiple patients are screened and how their antenatal visits are done in an OPD setting. So stay tuned for those videos and it will be easier for you to remember. So at each antenatal visit, we measure weight, we measure BP, we do a urine districts test for proteinuria. Glycosuria is normal, but proteinuria is not normal. That it indicates pregnancy-induced hypertension. Blood glucose monitoring second trimester every 2 weeks, third trimester every week. Fundal examination rule out diabetic. So fundal examination in the mom to rule out diabetic retinopathy. Investigation ultrasound, screening ultrasound, level 1 ultrasound at 18 to 20 weeks. TIFA target scan, level 2 ultrasound to detect gross congenital anomalies. At 22 to 24 weeks, fetal echo to rule out ventral septal defect, which is like most common defect. Urine routine and microscopy in every trimester to rule out asymptomatic bacteriuria, which is more than 10⁵ bacterial colony, plus minus urine culture and sensitivity. Fetal monitoring. Begin from 32 weeks of pregnancy. NST non-stress test weekly, biophysical score weekly, growth scan 3 weekly, rule out polyhydramnios and macrosomia, at least 2 growth scan at 28 to 30 weeks and 34 to 36 weeks. Minimum time gap is 3 weeks. Umbilical artery Doppler. Indication: diabetic vasculopathy, development of pregnancy-induced hypertension. All the above investigations are done in gestational diabetes mellitus except fetal echo, no suspicion of CVS anomalies. Treatment: medical management, weight counseling plus medical nutrition therapy, diet modification, insulin drug of choice for treatment of diabetes in pregnancy, low dose aspirin to prevent pregnancy-induced hypertension, obstetric management, termination of pregnancy, induction of labor more than equal to 39 weeks, mode of delivery vaginal, indication of C-section, weight of baby more than 4.5 kgs. Gestational diabetes features: occurs due to increased insulin resistance in normoglycemic female. Complications similar to pre-gestational diabetes except no gross congenital anomalies in gestational diabetes mellitus because the free radicals are not able to cross the placenta. Organogenesis is already completed by then. Follow-up same as in gestational diabetes mellitus. Investigation same except fetal echo is not done in gestational diabetes mellitus because there are no congenital anomalies. Diagnosis: DIPSI criteria. Recommendation: first test, first antenatal visit. Repeat 24-28 weeks of pregnancy. First visit after 28 weeks, only one test. Minimum time gap is 4 weeks. Procedure: no fasting is required. Universal screening irrespective of previous meals. 75 gram of glucose in 300 milliliters of water. Can add lime. Consume in 5 to 10 minutes. Check 2-hour postprandial sugar levels using plasma calibrated glucometer. Patient vomits within 30 minutes. Repeat test on another day. After 30 minutes, continue test. 2-hour postprandial interpretation. First antenatal visit. Less than 140, repeat at 24 to 28 weeks. More than equal to 140, gestational diabetes mellitus. More than equal to 200, pre-gestational diabetes mellitus. This is at the first antenatal visit. If they come at 24 to 28 weeks and if it's less than 140, non-diabetic, more than equal to 140, gestational diabetes mellitus, 200, treatment with insulin. Management of gestational diabetes depending on 2-hour postprandial values. 140 to 199 milligram per deciliter initial MNT for 2 weeks management. Metabolic goals. Fasting blood sugar should be less than 95. 1 hour should be 140 and 2 hour postprandial should be less than 120. HbA1c should be less than 6%. Average capillary glucose should be less than 100 milligram per deciliter. If 2 hours postprandial is more than 200, immediate 8 units of insulin plus MNT plus weight counseling and no role of aspirin. If goals are met, continue MNT, advise 30 minutes walk daily, check 2 hours postprandial levels, second trimester every 2 weeks, third trimester weekly, minimum at least monthly. Goals not met, start metformin, more chosen than insulin plus MNT. Note: guideline for treatment. Diagnosis: if before 20 weeks we give metformin. If diagnosis is less than 20 weeks, so diagnosis after 20 weeks is metformin, diagnosis less than 20 weeks is insulin, 2 hours postprandial anytime is more than 200 is insulin. Medical nutritional therapy. Balanced diet. Carbohydrate controlled balanced diet. Carbohydrate 40%, fat 40%, protein 20%. Distributed over 3 meals plus 3 snacks. Caloric requirement: add 350 kilocalorie to all pregnant females. BMI less than 18.5, extra 500 kilocalorie per day. BMI more than 25, subtract 500 kilocalorie per day. Oral hypoglycemic agents. Metformin, recommended by GOI. Used only in gestational diabetes mellitus, not in pre-gestational diabetes mellitus. Used only if more than 20 weeks of pregnancy. First line drug. Advantages: decreased chances of excessive maternal weight gain, decreased risk of neonatal hypoglycemia, decreased risk of large for gestational age fetus, decreased risk of macrosomia, preferred in obese women. Dose: 500 mg per day up to 2 gram per day. If dose required is more than 2 gram per day, then add insulin. Side effect: most common side effect are GI side effects. Most dangerous is lactic acidosis. Glyburide. Glyburide dose 2.5 mg per day up to 20 mg per day. So up to 10 times, 2.5 and up to 20. Side effect: increased risk of neonatal hypoglycemia. Insulin type: human premix insulin 30, short acting insulin 30%, 70% intermediate insulin. So insulin 30% short acting, 70% long acting, intermediate acting. 1 vial 40 international units. Storage 4 to 8 degrees Celsius. Syringe reused 14 times. Insulin requirement increased with advancing pregnancy. Decrease in labor. Patient nil per oral, so decreased in labor. Administrating insulin, start human insulin premix 30:70, subcutaneous injection 30 minutes before breakfast, one time. Dose of insulin calculated by 2-hour postprandial levels. 2-hour postprandial levels, dose of insulin between 120 to 160, 4 units, between 160 to 200, 6 units, more than 200, 8 units. Check levels on third day, goals met, continue same dose of insulin, goals not met, fasting blood sugar is more than 95, 2 hours postprandial is more than 120, add 2 units insulin pre-dinner, add 2 units insulin before breakfast if the postprandial is high. Check levels more than 3 days. Titrate dose as required till metabolic goals are met. Once met, check every 2 weekly in second trimester and weekly in third trimester. Termination of pregnancy. Well controlled on diet, type A, more than equal to 39 weeks. Gestational diabetes mellitus, controlled on drugs. Type A2, well controlled more than 39 weeks, not well controlled more than 37 weeks. Mode of delivery is vaginal. Indication of C-section is when baby is more than 4.5 kgs. Intrapartum management. Mild gestational diabetes mellitus, on medical management, skip morning dose, 2-hourly blood sugar monitoring with glucometer, during labor, nil per oral, IV NS at 100 mils per hour, plus minus insulin depending on the blood sugar level. Blood sugar level 90 to 120 milligram per deciliter, amount of insulin added in 500 milligram and normal saline. 90 to 120, no need of insulin. More than 180, 8 units. Until 140, minus 2. 120, minus 2. If blood glucose is less than 70, that is hypoglycemia, start 5% dextrose. Postpartum management. Check blood sugar, day 3 of delivery, discharge, 6 weeks follow-up, 75 gram 2-hour oral glucose tolerance test, normal, confirmation of gestational diabetes, advise annual 75 gram oral glucose tolerance test once in a year, increased risk of developing type 2 diabetes mellitus. Pre-gestational diabetes, insulin requirement decreased. From day 2 of delivery, shifted back to oral hypoglycemic agents, refer to endocrinologist if required. Complications and lung maturity tests. Complication, maternal complications, hyperglycemia, infections, polyhydramnios, oligohydramnios, big placenta, risk of type 2 diabetes mellitus in future, C-section, ketoacidosis. Maternal complications, hyperglycemia, infections, increased risk of asymptomatic bacteriuria, candidiasis, puerperal sepsis, polyhydramnios due to and polyhydramnios can cause preterm labor, premature rupture of membranes, cord prolapse, postpartum hemorrhage, subinvolution. Oligohydramnios if diabetic vasculopathy or pregnancy-induced hypertension is present. Big placenta, placentomegaly, swelling of chorionic villi due to hyperglycemia, increased risk of pregnancy-induced hypertension and placenta previa, increased risk of type 2 diabetes mellitus in future, cesarean section and ketoacidosis. Note: pre-gestational diabetes with retinopathy during pregnancy. Retinopathy worsens. In all females with pre-gestational diabetes, conduct baseline fundal examination. Hypoglycemia. Blood sugar less than 70 mg per deciliter. Symptoms: tremors, sweating, palpitation, extreme fatigue, tingling sensation. Management: 3 tablespoons of glucose in 100 milliliter water or 6 tablespoons of sugar in 100 milliliter of water. Fetal complications. Maternal hyperglycemia, that is equal to fetal hyperglycemia, stimulates fetal pancreas, hyperinsulinemia, increased growth, macrosomia, decreased lipolysis, increased fat deposition around fetal shoulder dystocia. Macrosomia can cause prolonged labor, increased chances of C-section. Note: hormone released for fetal growth is insulin and IGFs, growth factors, insulin dependent growth factors. IUGR only if diabetic vasculopathy is present or pregnancy-induced hypertension is present. Increased risk of abortion in uncontrolled diabetes. Risk of stillbirth due to macrosomia, increased oxygen demand, increased hypoxia, fetal death or stillbirth. Hyperglycemia, oxidative stress, hypoxia, fetal death or stillbirth. Edema of chorionic villi, decrease in oxygen transport, hypoxia, fetal death or stillbirth. Most common in the last 2 weeks of pregnancy. Congenital malformation only if fetus is of a pre-gestational diabetic mother. Neonatal complication. Or neonatal complications. So neonate, after the birth is given. Neonatal hypoglycemia, maternal hyperglycemia, fetal hyperglycemia, increased fetal insulin. At birth, connection between mother and fetus is lost. No source of glucose but increased insulin, hypoglycemia. Note: anemia as a complication is not seen. Hypocalcemia, hyperkalemia, hypomagnesemia triggered by hypoglycemia. Respiratory distress syndrome and necrotizing enterocolitis (NEC), increased insulin suppresses surfactant production. That is, increased insulin, it suppresses the production of surfactant, and that's why there is respiratory distress syndrome and necrotizing enterocolitis. Hypoxia, increased erythropoietin, hypertrophic obstructive cardiomyopathy. Polycythemia causes hyperviscosity and hyperbilirubinemia. Late complications in a child. Type 2 diabetes mellitus 1 to 3%. Obesity, metabolic X syndrome. Lung maturity test done via amniocentesis in third trimester. So in the third trimester you can do amniocentesis. Lung maturity test done via amniocentesis in the third trimester. Lecithin sphingomyelin ratio. Most common test is lecithin sphingomyelin ratio. Mature lungs, it has more than equal to 2:1. So 2 lecithin, 1 sphingomyelin ratio. Immature will be less than that. So lecithin will not be the double of sphingomyelin. Phosphatidylglycerol best test done after 35 weeks. Present, mature, absent, immature. Lamellar body count. Type 2 pneumocytes produce surfactant. Release as packets called lamellar bodies. Less than 50,000 per ml, not mature. More than 50,000 per ml, 100% lungs mature. Positive test 30,000 to 40,000 ml. Bedside test, shake test, bubble test, obsolete. Nile blue sulfate test, obsolete. Principle: AF has fetal skin cells. So amniotic fluid has fetal skin cells. Mature at the same time as lungs. Procedure: take amniotic fluid in a test tubes. A Nile blue sulfate dye. Prepare, slide and examine under microscope. Blue cells, immature skin cells. Orange cells, mature skin cells. Interpretation: more than 50% orange skin cells, that is more than 50% mature skin cells, indicates that the lungs are mature too. Shoulder dystocia, obstetric emergency. Features: inability to deliver fetal shoulder within 1 minute of head delivery. Turtle sign positive. Receding of fetal head into perineum. Management: helper, call for help, liberal episiotomy, legs maneuver, Mac-Roberts maneuver, first and most effective maneuver, flexion and abduction of legs against abdomen, straightening of sacrum. So flexion and abduction of legs towards abdomen, straightening of sacrum. Decreased available space, no increase in pelvic diameter, fails. Suprapubic pressure, Mac-Roberts maneuver, sustained in thirst. Available space in Mac-Roberts maneuver. Enter maneuver, manual rotation of shoulders, Wood corkscrew maneuver, both shoulders. Rubin's maneuver, only one shoulder. Remove, deliver posterior arm of baby, Jacquemeyer maneuver. Roll on all 4 limbs, all 4 maneuver, Gaskin's maneuver. Zavanelli maneuver, last step, push fetal head back into uterus, C-section. In dead babies, fracture clavicle of baby, cleidotomy. Symphysiotomy, dividing pubic symphysis of mother, obsolete. Contraindication in management is fundal pressure. Gaskin maneuver is shown in that image. Wood corkscrew maneuver, delivering both shoulders. Complications. Each maneuver performed for a maximum of 30 seconds. Fail, next step. Complications. Fetal Erb's palsy, most common. Injury to C5 and C6. Arm position, internally rotated, abducted and pronated. Maternal postpartum hypertension, most common. Note, most common nerve injured during McRoberts maneuver is lateral cutaneous nerve of thigh. So that was all about DM. We completed it. You just have to listen it for 3 times. And then now we have pregnancy induced hypertension. The third topic, last topic. Definition. Blood pressure more than 140/90 on 2 occasions, 4 hours apart, systolic, diastolic both in pregnant female. So 140/90. Exception. If BP is more than 160/110, repeat in 15 minutes, again 160/110, start antihypertensives. Chronic hypertension in pregnancy versus pregnancy-induced hypertension. So presentation. Chronic hypertension is hypertensive female has conceived, past history of increased blood pressure. Pregnancy-induced hypertension. Normotensive female has conceived, no past history of increased blood pressure. Increased blood pressure since day 1 of pregnancy. After 20 weeks of pregnancy due to placental pathology. Normalization of blood pressure after delivery within 12 weeks of delivery. Preeclampsia versus gestational hypertension. BP increases in both preeclampsia and gestational hypertension after 20 weeks of pregnancy. Proteinuria, positive, non-selective, is present in preeclampsia and absent in gestational hypertension. Signs of end organ damage is present in preeclampsia but absent in gestational hypertension. Proteinuria is excretion of protein in urine more than 300 mg per 24 hours. Protein creatinine ratio is more than 0.3 in urine. Urine dipstick OPD basis, you can see more than equal to +1. Proteinuria. Signs and end organ damage. Platelet count less than 1 lakh. Liver enzyme SGOT, SPHGT raised more than 2 times the normal. Earlier we have read that SGOT and SGPT are never physiologically increased in pregnancy. So if you see something like that, it means there is an end organ damage. Serum creatinine more than 1.1% milligram per deciliter. Pulmonary edema, visual symptoms, cerebral edema. Note. ALP, alkaline phosphatase, is produced by placenta, so that is raised in pregnancy. It is a heat stable protein. Antenatal visit and pregnancy induced hypertension. At every visit, measure BP. If more than equal to 140/90 after 4 hours, repeat BP. Screening test, urine dipstick for proteinuria more than equal to 1+. Diagnostic test, 24 hours urine protein excretion, gold standard. Chronic hypertension with superimposed preeclampsia. Hypertensive female conceives. So chronic hypertension with superimposed preeclampsia. So they were hypertensive and then became preeclamptic. End organ damage, proteinuria, etc. So hypertensive female conceives at 20 weeks, suddenly develops any of the one of the following symptoms, signs. So such as uncontrollable blood pressure, develops new onset proteinuria, Develops new onset signs of end organ damage. Bad prognosis. Prevention. All pregnant chronic hypertension patient low dose aspirin started daily from 12 weeks onwards to prevent superimposed preeclampsia. So to prevent this, all pregnant chronic hypertensive patient low dose aspirin started after 12 weeks, which is 3 months, to prevent superimposed preeclampsia. Mild versus severe preeclampsia. Differentiating features. Mild preeclampsia, blood pressure could be 140/90, less than 160 and 110. More than 160 and 110 is severe preeclampsia. Signs of end organ damage is absent in mild preeclampsia and present in severe preeclampsia. Symptoms of impending eclampsia is absent in mild preeclampsia and present in severe preeclampsia. Note: complication of severe preeclampsia. Eclampsia and HELP syndrome. In our preeclampsia patient, you have to admit them. 3 important investigations: LFT, SGOT, SGPT, serum creatinine, platelet count. Non-differentiating features in mild and severe preeclampsia: degree of proteinuria, oligouria, decreased blood volume to kidney, decreased GFR, intrauterine growth retardation, decreased blood volume to fetus, IUGR. Pathological edema does not subside on rest, seen on both dependent and non-dependent body part. I had seen one such patient who was a preeclampsia and her vulva was enlarged to an extent that she couldn't walk. Signs and symptoms of impending eclampsia: severe headache, not relieved by usual medication, epigastric pain due to subcapsular hematoma, stretching of liver capsule, visual disturbances. For example, diplopia, blurring of vision, scotoma, blindness. Fundal examination be done. Eclampsia. Definition: severe preeclampsia, generalized tonic-clonic seizures. Once when I was doing duty in labor room, then there was this lady who was brought into the OBGY department, and she had already delivered her child, like postpartum period, and she went into eclampsia, and at home she was having seizures, and because of the seizures she had cut her tongue because of the clenched jaw and her teeth. It cut her tongue, and it was bleeding profusely. She could not open her mouth, and then she was unconscious and was all convulsed, and that is how she presented in the emergency department of OBGYN. Types: antepartum, intrapartum, postpartum. Antepartum, in antenatal period, most common type, worst prognosis. So when it is during the pregnancy. Intrapartum is during labor, and postpartum is after delivery within 48 hours. Atypical eclampsia signs: onset of seizure, more than 48 hours of delivery, less than 20 weeks of pregnancy, prolonged loss of consciousness, persistent neurological deficit. Pregnant female doesn't meet the criteria of preeclampsia. Investigation of choice: MRI. In posterior reversible encephalopathy, edema localized to posterior cerebral hemisphere. In posterior reversible encephalopathy, edema localized to posterior cerebral hemisphere. Note: gestational hypertension. 50% gestational hypertension cases changes to preeclampsia. If gestation hypertension blood pressure more than equal to 160 and 110 mmHg, managed like severe preeclampsia. First antenatal visit after 20 weeks. Plus patient found to be hypertensive. Hypertension status unknown. No proteinuria, signs of end organ damage. Provisional diagnosis: gestational hypertension. Recheck blood pressure after 12 weeks of delivery. Blood pressure normal values: gestational hypertension, transient hypertension in pregnancy. Blood pressure still raised, revised diagnosis: chronic hypertension. Pregnancy induced hypertension part 2. Events in normal pregnancy: extravillous trophoblast endovascular part. In normal pregnancy, replaces lining of spiral arteries, converts high resistance vessels to low resistance vessels, maintains uteroplacental circulation. Known as trophoblastic invasion vascular remodeling. 2 phases. First phase is 12 weeks, lining of decidual segment is replaced. Second phase 16 to 20 weeks, lining of myometrial segment is replaced. Maternal NK cells play a role in remodeling. This is the placenta, this is the decidua, this is the myometrium, arcuate artery, spiral artery, trophoblast. Pathophysiology. Incomplete trophoblastic invasion. Second phase incomplete. In pregnancy induced hypertension, only first phase. Leads to resistance remains high, decreased blood volume in intervillous space, placental ischemia, incomplete trophoblastic invasion. Second phase is incomplete. First phase, as you can see, only the decidua underwent remodeling, but the myometrium did not. So resistance remains high, decreased blood volume in intervillous space, placental ischemia. Placental ischemia. Size of placenta decreases. Uteroplacental insufficiency comes into place. Decreased blood supply to fetus causes intrauterine growth retardation, brain sparing effect, increased flow to brain, decreased renal blood flow, oliguria, oligohydramnios. Release of mediators into maternal blood, increased vasoconstrictor, decreased vasodilator. Increased vasoconstrictor, SFLT, soluble FMs like tyrosine kinase. Serum endoglobin, intraleukins, TNF alpha, thromboxane A2, increased sensitivity to angiotensin enzyme, anti-angiogenic factors, decreased vasodilators, VEGF, placental growth factor, nitrous oxide, prostacyclin 1-2, angiogenic factor, decreased activity of angiotensinase enzyme. Release of mediators in maternal blood, vasoconstriction and endothelial injury. Release of mediators in maternal blood, vasoconstriction. Increased blood pressure, first clinical manifestation of pregnancy induced hypertension after 20 weeks. Endothelial injury, capillaries become leaky, fluid accumulates in third space, pathological edema, ascites. Inside the vessel, hemoconcentration, stasis of blood, platelet activation and aggregation, endothelial injury, Virchow's triad, increased chances of thrombosis and organ damage, multiple organ failure. Main factor, placenta, independent of fetus. For example, molar pregnancy. Definitive treatment, termination of pregnancy, first organ involved in pregnancy induced hypertension, maternal kidney. Histopathology, glomeruloendotheliosis. Increased blood pressure to kidney decreases, RBF decreases, oliguria, decreased GFR, decreased filtering capacity of kidney, increased serum urea, increased serum uric acid, increased serum creatinine. Note, serum creatinine more than equal to 1.1 mg per deciliter and organ damage. Cerebrovascular pathology, leaky capillaries, endothelium of brain, cerebral edema, induced hypoxia, release of excitatory neurotransmitters, eclampsia, convulsions. Loss of cerebral autoregulation, cerebral hyperperfusion, throbbing, severe headache, visual disturbances, involves occipital lobe mainly. Factors affecting for pregnancy-induced hypertension. Risk factors. Female exposed to placenta for first time, primigravida, new paternity, long interpregnancy interval, placental tissue increased, placentomegaly, twin pregnancy, diabetic patient, Rh negative pregnancy, molar pregnancy, early onset preeclampsia less than 20 weeks, autoimmune disease, EPLA, SLE, protective factors, smoking. Patient's details, pregnancy less than 18 years old and more than 40 years old, obesity, calcium deficiency, genetic predisposition, previous history of in vitro fertilization, chronic hypertension, pregnancy induced hypertension, chronic kidney disease. Prevention of pregnancy induced hypertension. Proven role: aspirin, weight loss, calcium supplements, useful only if calcium deficiency. So all of you can start on working on this weight loss if your BMI is high. No proven role: antioxidants, fish oil, vitamin E, absolute bed rest, salt restriction. ACOG recommendations in following diseases, that is APLA syndrome, chronic hypertension, multifetal pregnancy, kidney disease, diabetes. Give low dose again. Start at 12 weeks, not later than 16 weeks, end at 36 weeks. Dose is 80 to 150 milligram. One tab is 75 milligram. They are talking about aspirin. Predictors of pregnancy induced hypertension. New predictors: increase SFLT1, increase endocrine, decrease vascular VGEF, decrease placental growth factor, SFLT1 PL growth factor best. Outdated predictors: Giant's rollover test, angiotensin 2 challenge test. Others: uterine artery Doppler. Uterine artery Doppler. In a normal pregnant female, diastolic notch is present. Pregnancy progresses, decrease peripheral vascular resistance. Notch disappears by 20 to 22 weeks. And here, systolic wave, and diastolic notch in between them. Diastolic and diastolic pressure is absent or reversed in increased in pregnancy induced hypertension. Uteroplacental insufficiency. Predictors of pregnancy induced hypertension on uterine artery Doppler: persistent of diastolic notch, increase pulsatility index, increase resistance index. Period of gestation. To predict pregnancy induced hypertension, 22 to 24 weeks. To predict early onset preeclampsia, 11 to 13 weeks. Pulsatility index or resistance index. Management of pregnancy induced hypertension. Investigations. All pregnancy induced hypertension cases should be admitted, proper history taken, lab test, fundal examination. In lab test, you do liver function test, serum creatinine, platelet count, LDH, peripheral blood smears for schizocytes to rule out HELP syndrome, LDH and peripheral blood syndrome. Check for BP more than 160/110, signs of end organ damage present, severe preeclampsia, remain admitted, mild preeclampsia, managed on OPD basis. Definitive management: termination of pregnancy, induction of labor. Conditions: mild preeclampsia 37 weeks, severe preeclampsia 34 weeks, eclampsia, impending eclampsia, HELP syndrome, pregnancy induced hypertension with fetal distress, pregnancy induced hypertension with abruption, immediate termination of pregnancy irrespective of gestational age, chronic hypertension 37 to 38 weeks, chronic hypertension with superimposed preeclampsia 37 weeks. So here you can see that termination of pregnancy is done at 37 weeks in all in all high blood pressure cases, but in severe preeclampsia, it is done at 34 weeks. That's the easiest way to remember. Monitoring in pregnancy induced hypertension. High risk pregnancy. Fetal monitoring starts from 32 weeks. Fetal monitoring chest. Mild preeclampsia and severe preeclampsia. Daily fetal movement count. Daily. Non-stress test. Weekly. Biophysical score weekly, while alternate day in severe preeclampsia. Ultrasound for fetal growth every 3 weekly, every 2 weekly. Umbilical artery Doppler should be done. Umbilical artery Doppler. Finding in pregnancy induced hypertension and uteroplacental insufficiency. Finding ST ratio of umbilical artery is more than equal to 3. Termination of pregnancy 37 weeks. Absent end diastolic flow 34 to 33 weeks. Reverse end diastolic flow 31 to 32 weeks. You have to terminate the pregnancy. Management of mild preeclampsia without severe features. That is OPD basis treatment. Approach: BP monitoring twice daily. Fetal monitoring start at 32 weeks. Educations on signs and symptoms of impending eclampsia. Treatment: antihypertensives if more than 160-110 mmHg. IV antihypertensives given IV more than 150-100 mmHg and more than 160-110 mmHg oral. That is the NICE guideline. Most commonly given is labetalol. No role of aspirin, bed rest, salt reduction, magnesium sulfate if both mild and severe preeclampsia. Definitive management: termination of pregnancy at 34 weeks by induction of labor. Management of severe preeclampsia with severe features. Treated inpatient. Evaluation, lab investigation plus fundal examination. Treatment: magnesium sulfate prevents seizures. Antihypertension prevent intracranial hemorrhage. Corticosteroids first dose. Evaluate. Emergency conditions: terminate pregnancy after first dose. Conditions: HELP syndrome, impending eclampsia, fetal distress, placental abruption, disseminated intravascular coagulation, pulmonary edema, complete corticosteroid course, gestational age less than 34 weeks, continue pregnancy till 34 weeks, plus fetal monitoring, umbilical artery Doppler, continue antihypertensive, gestational age more than 34 weeks, induction of labor. Complications: abruptio placentae most common. Termination of pregnancy in mild and severe preeclampsia. Mode of delivery: vaginal. C-section only in obstetrical indication. Anesthesia: neuraxial anesthesia more than epidural anesthesia. Management of preeclampsia: patient with convulsions. Step 1: raising bed rails, airway management. Step 2: magnesium sulfate to treat convulsions. Antihypertensive IV route. Definitive management: termination of pregnancy irrespective of gestational age. Mode of delivery vaginal delivery. Indication of C section only in obstetrical indication. Anesthesia general anesthesia. Impending eclampsia seen in patients of severe preeclampsia. Signs and symptoms: severe headache 70%, epigastric pain due to subcapsular hematoma, visual disturbances. Management: magnesium sulfate to prevent seizures, antihypertensive drugs, termination of pregnancy after stabilization, irrespective of gestational age. Note: visual disturbances in preeclampsia, blurring of vision, scotoma, diplopia, blindness. 10 to 15% cases of severe preeclampsia. Reversible, exception due to retinal artery occlusion or retinal detachment. Causes: occipital blindness, amaurosis fugax, cerebral infarct, retinal ischemia and detachment, retinal infarction, personal retinopathy. Classification of hypertensive retinopathy. Keith Wagner classification. Eclampsia with fetal classification of hypertensive retinopathy. Keith Wagner classification. Eclampsia with fetal distress. Stepwise management. Check fetal heart rate, sound. Fetal distress present. Rule out abruptio placentae. Caesarean section plus minus. Fetal heart sound becomes normal. Continue eclampsia management. Antihypertensives in pregnancy induced hypertension. Indication: blood pressure decreased by less than 160 mmHg. Nice guidelines more than equal to 150 and 100 mmHg persistently. Um, Target blood pressure 130 to 140 and 80 to 90. Note: overcorrection of blood pressure should not be done if hypotension, decreased uteroplacental perfusion, fetal distress. Drugs for placental eclampsia. Sorry, drugs for preeclampsia. First line drugs: levetolol, hydralazine, nifedipine. Other: verapamil, side nitroglycerin, ketanserin, nimodipine, nicardipine, nitroprusside, least preferred. Drugs for severe preeclampsia, hypertensive crisis. Blood pressure more than equal to 110, 160 and 110 mmHg. IV antihypertensive drugs. Labetalol, IV route. 20 mg IV. Check BP in 15 minutes. 40 mg 15 minutes. 80 mg 15 minutes. 80 mg. Maximum dose 220 mg. Contraindicated in bradycardia and asthma. Note: alpha methyl dopa, slow acting drug so not used as first line of severe preeclampsia. Hydralazine, IV route. 5 mg IV, 20 minutes, 10 mg IV. Maximum dose 30 mg. Oral nifedipine, not sublingual. Drugs for chronic hypertension. First line drug. Oral route. Methyl-dopa, labetalol, nifedipine. Also used if preeclampsia if BP is more than equal to 150/100 and less than equal to 160/110. Contraindicated hypertensives, antihypertensives in pregnancy. ACE inhibitors, dioxazide, um, ARBs. For example, um,
angiotensin receptor blockers, for example, losartan, beta blocker, except labetalol. Diuretics, not absolutely contraindicated in preeclampsia because of hemoconcentration, can be used in chronic hypertension, not first line, and should be used before 20 weeks. Used in pulmonary edema and congestive heart failure. Magnesium sulfate. Prevention and treatment of seizure in hypertensive pregnant female. Mechanism of action. Centrally acting drugs acts on NMDA receptors, decrease cerebral edema, decrease oxidative stress, stabilize membrane potential, therapeutic range 4 to 7 mg, narrow therapeutic range. Regimens. Pritchard regimen, followed in India. Loading dose IM 10 mg of 10 grams of 50% magnesium sulfate, 5 gram in each buttock, plus IV 4 gram of 20 magnesium sulfate. So IM 10 grams of 50% magnesium sulfate, 5 grams in each buttock, IV 4 gram of 20% magnesium sulfate. Preparation of dose. 1 ampule of magnesium sulfate is equal to 2 ml of magnesium sulfate equals to 1 gram of magnesium sulfate, 50% solution of magnesium sulfate. So 1 ampule is equal to 1 gram. For loading dose, IM dose 10 milligrams, 10 ampules, because 1 ampule is 1 gram. IV dose 4 grams equals to 4 ampules. IV dose preparation. In 20 ml syringe, 4 ampules of magnesium sulfate plus add 12 ml NS, 20 ml solution. 4 milligram magnesium sulfate, 20% concentration. Note: for loading dose, renal function is not checked, given irrespective of renal status. While giving IV, monitor maternal heart rate. Maintenance dose. That's regimen I'm reading again, which is followed in India. Loading dose. 10 milligram of 50 magnesium sulfate, 5 gram in each buttock, and 4 gram of 20 milligram sulfate. So एक एम्प्यूल में 1 ग्राम आता है, आपको देना है 5 ग्राम दोनों बटक में 50% कॉन्सेंट्रेशन में. तो आप 5 एम्प्यूल मैग्नीशियम सल्फेट लोगे और उसके अंदर और वो हो जाएगा 50%, क्योंकि 1 एम्प्यूल मैग्नीशियम सल्फेट में 2 म्यूल मैग्नीशियम सल्फेट होता है, तो 1 ग्राम. सो फॉर लोडिंग डोज 10 ग्राम 10 एम्प्यूल्स. IV डोज 4 ग्राम 4 एम्प्यूल्स. IV डोज में 20 ml सिरिंज में 4 एम्प्यूल्स मैग्नीशियम सल्फेट में 12 ml NS, तो 20% सोल्यूशन बन जाएगा. Note: for loading dose, renal function is not checked, given irrespectively of renal status. While giving IV, monitor maternal heart rate. Maintenance dose IM 5 gram 50% solution every 4 hourly in alternate buttocks. To be given till 24 hours after delivery or 24 hours after last conversion, whichever is later. Before giving maintenance dose, check for deep tendon reflex, knee jerk present, respiratory rate more than 12 per minute, urine output more than 100 cc per 4 hours, given only if all three is positive. So what three things should be positive? Knee jerk, deep tendon reflex, respiratory rate more than equal to 12 per minute, urine output more than equal to 100 cc per 4 hour. Zuspan Zibai regimen, ACOG recommended. Loading dose 4 to 6 gram diluted in 100 ml IV fluid over 15 to 20 minutes. Maintenance 1 to 2 gram per hour in 100 ml IV infusion. Magnesium sulfate toxicity signs and symptoms. So जो 3 साइंस पॉजिटिव होने चाहिए वो नेगेटिव हो जाएंगे. तो टॉक्सिसिटी क्योंकि वही मॉनिटर करना है लोडिंग डोज देने से पहले. सो व्हाट आर द टॉक्सिसिटी सिम्टम्स? फर्स्ट साइन loss of knee jerk 9 to 10 milliequivalent per liter. Other symptoms oliguria is not a sign of magnesium sulfate toxicity. Urine outburst is checked because magnesium sulfate is excreted by kidney. Antidote for magnesium sulfate toxicity is calcium gluconate, 10 ml of 10% IV route. Uses prevent seizure, severe preeclampsia, impending preeclampsia, HELP syndrome, seizure preeclampsia, neuroprotein, neuroprotection, all preterm labor less than 132 weeks, tocolytic action, dose dependent, not used, side effect appears